My name is Jonathan Lee. I'm one of the PGY3s at UCSD, and thank you everyone for staying for the last session of the last day. And today we will be presenting our work on ERAS and minimally invasive inguinal hernia repairs. Our disclosures are listed here. Supposed to keep it up for 7 seconds. Sounds like about 7. So inguinal hernia repairs are one of the most common general surgery procedures done around the world, with roughly 20 million done annually. Elective results generally are pretty favorable. However, significant complications such as postoperative urinary retention, or POR, and uncontrolled postoperative pain can occur and are quite vexing for both patients and surgeons. And with the recent rise of ERAS protocols, we postulated that if we transition these inpatient principles to an ambulatory setting, we can help decrease these and improve these morbidity rates. We performed a retrospective review of a prospectively maintained database looking for minimally invasive hernia repairs. Our primary outcomes included POR and uncontrolled postoperative pain. We define POR as patients who either required an indwelling Foley catheter upon discharge, who returned to the emergency department for treatment of urinary retention, or who were admitted post-op for retention. Uncontrolled postoperative pain was defined similarly, and it was patients who were either admitted for pain control, came back to the ED for pain control, or required additional narcotic scripts after discharge. Oh, that is the wrong button. Our ambulatory ERAS protocol consisted of a multimodal, multidisciplinary approach with both preoperative, intraoperative, and postoperative components. Major key components were to try to minimize narcotic usage, and when using narcotics, have a tendency for the shorter acting agents such as fentanyl, and have goal-directed fluid therapy with a goal of 500 cc's or less should patient hemodynamics allow, as well as discharging patients without a narcotic script. These are our patient demographics. We had roughly 1,100 patients, mean age of 57. The vast majority of them were male, and 90% of it was done laparoscopically. The follow-up time was a mean of 43 days. Our primary outcomes are listed here. We discovered a total of 33 patients with POR, equaling roughly 3% of the patient population, and 25 patients with uncontrolled postoperative pain. Our first comparison, we wanted to compare our ERAS group versus non-ERAS group. We defined our ERAS group as patients having their operation after or in 2018, as that's when we started our protocol. There were roughly 43% of the total population was ERAS, and the main demographic difference was a slight difference in ASA score, with non-ERAS being a little bit higher. In terms of operative time, there was no difference, but there was a significant difference in POR rates, with our ERAS group having 1.4% versus the 4.2% in the non-ERAS group. There was also no significant difference between rates of uncontrolled postoperative pain. To further try and elucidate this difference in POR rates, we examined intraoperative variables. We looked at intraoperative narcotic use, PACU narcotic use, and total narcotic use. There was a difference between all three of them, with the ERAS having significantly less total narcotic use. We converted all of the narcotic doses to a oral morphine milligram equivalent for our analysis. In terms of our narcotic discharge versus no discharge, the ERAS group obviously had more patients who were discharged without narcotics, and the ERAS group also had a lower volume given within the operating room of fluids. This is a graph demonstrating our rate of narcotic-free discharge compared to our rates of POR. As you can see, even though we started in 2018, it took a couple years for our practitioners to become comfortable with the ERAS protocol and to accept it into their practice. And then by 2021, we had close to 90% compliance with our ERAS protocol, and our POR rate subsequently decreased as well during this time period. Regarding that, one of our major components of the protocol is to try and discharge our patients without a narcotic script. In terms of these two groups, the main difference was there was more male patients, and both of the male patients were pretty predominant, no difference in operative time. But in terms of the patients discharged without a narcotic script, there was no incidence of POR. And our rates of uncontrolled pain was also not significantly different between the two groups as well. Another aspect we wanted to examine was intra-operative adjuncts, mainly sugammadex and dexamethasone, to try and decrease rates of POR. We found that patients who were given sugammadex had much lower rates of POR at 0.6 compared to patients without at 5.6, and dexamethasone had similar results, 2.4 versus 6.4. In the end, we did a multivariable analysis trying to find predictors and risk factors for POR, and we found that mainly fluid volume and higher PACU narcotics and total narcotics put patients at a slightly increased risk for POR, while ERAS protocol, sugammadex and dexamethasone were significant protective factors against postoperative urinary retention. In conclusion, POR and postoperative pain remain vexing complications for both patients and surgeons, incurring significant discomfort and cost despite the advent of minimally invasive repair. Translation of inpatient ERAS protocols to an ambulatory setting can help decrease these, and then narcotic-free discharge can adequately control pain and also allow surgeons an avenue to combat the opioid epidemic. Thank you very much.